Thank you for joining us this afternoon to discuss COVID-19 and MS. Dr. Enrique Alvarez, the Clinic Director at the Rocky Mountain MS Center at University of Colorado, will be answering common questions. We'll begin by answering the questions that we've already received, and then we will open it up to questions from viewers. You can enter questions at any time in the chat window on your screen. Always contact your MS care provider before making any changes to your treatment plan. Good afternoon, Dr. Alvarez. Thank you for joining us and sharing this important information. I'd like to start today with talking about what are the signs and symptoms of COVID-19.
Sure. So COVID-19, for the most part, is have similar symptoms to what most common cold patients would have. COVID-19 is caused by a coronavirus, and there's different strains of coronaviruses. Most of the common colds are strains off of the coronavirus that we see. It's a little bit of a different type of virus that causes the influenza or the flu. The COVID-19 is a type of virus that is tends to affect more kind of the lower respiratory tract, so more the lungs more than the upper airways. But you get a lot of the same kind of symptoms: fevers, runny noses, coughs, and things like that. So very similar to what you would think is a common cold. As everything, most patients, probably it's estimated that 80 to 85% of patients with COVID develop very mild symptoms, where only a small percentage, maybe around 5 to 10% of patients develop more severe symptoms, some of whom then would have to be hospitalized. And obviously the big concern is the deaths being caused by that. And we see that particularly more so at this point in patients who are older, particularly over the age of 70 and really 80. But we start kind of considering age of 60, 65 as sort of at-risk populations.
And does MS make COVID-19 worse?
So MS by itself does not. The concern with MS is for patients who have breathing issues. So MS patients who have respiratory compromise, who have a difficulty with choking, controlling their swallowing, those patients can go on to have more issues because they can't clear the virus as well. They're more likely to get secondary infections such as pneumonias and things like that. The other main concern, obviously, then when we start talking about MS patients is the patients who are on disease-modifying therapies or treatments that can lower the immune system. This is something that's being discussed a lot, and that is honestly a very hard question to answer at this point. There are many drugs that are being looked at to try and treat COVID-19, including some therapies that have been approved in China that actually lower the immune system. So it's hard to say how the MS drugs, I just learned a couple hours ago, for example, that Gilenya is actually being looked at in a trial to see if it could be used to treat COVID-19. So, I mean, there's a lot of efforts that are ongoing. The other medicine that we sometimes use in related conditions, particularly neuromyelitis optica, is tocilizumab, which inhibits a cytokine, or one of the chemicals that the immune system used to talk to each other, called interleukin-6 or IL-6. And so really whether or not we decrease the immune system and whether that's helpful or hurtful is something that we don't know. The stance that we've taken a little bit at the university is to weigh, I think, the risks and benefits. These are pretty much the national guidelines throughout. Everybody's opinions around risks and benefits varies a little bit. So, we're still trying to generate, I think, a lot of consensus around our group and as a MS treating community about the right approach and the right risks and benefits with some of the medications that we use. The main suggestions that we've come up as a group are to consider delaying therapies in some patients who may not necessarily be benefiting the most from these medications. Patients with progressive disease that maybe are still progressing and we're kind of on the fence as to whether this medication is particularly helpful, the B-cell directed therapies or the CD20 type therapies. Maybe some of those patients can kind of delay their treatments. And again, less concern, I think, at this time around whether lowering the immune system is hurtful, but more important with the idea of trying to reduce the contact with the healthcare system, leaving some of the resources in the clinics and in the hospitals, the infusion centers available should those resources be needed in the hospitals. And so in order to try and reduce the exposure of patients to the healthcare system, the recommendation is that patients who are okay pushing out infusions be pushed out, that labs for patients for just regular monitoring be pushed out for a couple of months. Same thing with routine monitoring MRIs. We can push those out some months as well. If a patient has abnormal labs and we're paying particularly close attention to them, again, the risks of coming into the hospital are pretty low, and so those we want to continue monitoring. The clinics are still open, and so I think it continues to be good to still think about why are we doing certain things and then whether we should proceed with that or not. So I think that becomes an important discussion to be calling into the clinic, for example, or things like that about where things stand. Again, most routine things, if we can push out for 1 to 2 or maybe 3 months, depending on how things progress from here, will allow us to have some flexibility to get the patients that really need to come into clinic.
So if a patient was recently seen within the last month or so and had a B-cell drug infusion, is there any increased risk for them?
Again, we don't have much information on this. We don't think that being on these drugs is increasing the risk of being immunosuppressed enough. We have to think that from the beginning to the end of the cycle of the treatment with those drugs, that the number of B cells is pretty much non-existent. So just having received something now versus towards the end of the cycle, for most patients, the B cells are pretty much gone. So there's not much difference at one point or another of the cycles to say that patients might be at higher risk for things. So I think part of it is being lucky and feeling good that you got treated and now you have a long time to kind of see where things develop. As a reassuring sign, we're starting to get reports of patients in other parts of the world that unfortunately have experienced COVID earlier than what we did, who were on those kinds of therapies and have done and were infected with COVID and have done, it sounds like, fairly well with sort of mild infections. And so it suggests at least that that patients can do really pretty well on these kinds of treatments. We're getting the same kind of reports with other therapies as well. And so that's the reassuring point.
So what are some special precautions that someone with MS might be taking at this time?
Yeah, so the two really big ones at this point are social distancing and washing your hands. So the idea is what we're really trying to do with some of these measures to limit contact with the healthcare system with social distancing is to decrease the chances of spread of the virus so that the healthcare system can deal with patients a little bit more gradually instead of having sort of a big jump in cases. This is a lesson that we learned from the 1918 pandemic with the Spanish flu. It's a lesson that we have seen in countries that took some of the social distancing measures early on. The spread in Singapore and in Japan showed much better flattening of the infection rate curve so that the system could deal with things a lot better than, for example, what we're seeing right now initially in the Wuhan province of China and in Italy, for example, where the system just gets inundated and swamp out the hospital systems to deal with patients that could otherwise maybe do okay. But we're noticing, for example, that certain patient populations in Italy, for example, aren't getting access to ventilators and things like that. So that's the main goal of that. The hand washing becomes particularly important as well. The idea a little bit is trying to reduce how much of the virus you do get exposed to. So there appears to be a big difference between sort of if somebody sneezes directly on you, you would get a lot more virus. If you're just touching something and you get a smaller load of the virus, you're much more likely to be able to fight off that infection and do very well with that as well. So if you do go out in public, changing clothes, washing hands, things like that should be all the measures that are getting recommended at this point. And so those are the two main things that I would think about to try and reduce, again, the spread at this time.
And from what it sounds like with the general guidelines that you've given, that should be really the entire household practicing, not just the person with MS.
That's correct. I mean, at this point, we're not really recommending that, the husband stay in one room, the wife stays in another room, and you keep the kids somewhere else. But the idea is to really try and give space to social networks so that you're not having big groups of people in close contact that could potentially be sharing the virus.
So moving kind of over to the clinic side of things, what are the options for telehealth visits at the Rocky Mountain MS Center?
Yeah, so let me introduce the concept of telehealth a little bit. There's many different things that have been changing a little bit with this, and it's a process that thankfully we were starting kind of fairly gradually as a clinic going back to last summer and ramping up slowly. As a department, we had done about 60 visits in November and December. We had jumped up to 90 by January. And now what we're finding out is we're doing about 1,000 visits a day, as a healthcare system here at the University of Colorado. It can involve different things. So, for example, one of the other hospitals we're affiliated with at Denver Health is doing a lot of telehealth or telephone visits, so kind of calling on the phone. Some of the rules were relaxed to allow for that because of this pandemic. For us at the clinic, we're doing these the way we had done them before the pandemic using teleconferencing software. It's called Video. Is the program. You connect into the patient portal at the university called My Health Connection, and then from there you have the ability to virtually log into a room that then you can do a face-to-face interaction through software to see the provider, where we can ask questions and interact with trying to do an exam, for example, even remotely, but where you can at least have a conversation and see each other. It's working out really pretty well. I would say we don't have the process perfected. It's pretty good for a lot of the patients that we had self-selected before, a lot of routine return patients. I think the system works really well. We're still working a little bit on the process around new patients. This, of course, has fed our process into having to figure out the system and how that's going to work. But I think we can learn pretty fast and manage to try and do a lot of these visits remotely like this. And again, the main goal of this is to try and reduce the number of patients having to get exposed to us in the clinic, and again, allowing for some of that social distancing. We can do pretty much every visit remotely. There's some limitations, obviously. It's hard for us to do spinal taps with the computer yet, so we're still having to learn and do some of the in-person visits. There's still some regulations that make it kind of tough. We got some rules relaxed around being able to do to allow us to do visits with patients who have Medicare. There was a big insurance that we were not able to do before the pandemic. The challenge that we're still having is some of our out-of-state patients related to licensing in other states and differences in malpractice groups and things like this. There's talk of relaxing some of those rules, but at this point, we still haven't been able to work through that completely.
So what if a patient is having a relapse? What steps should they take?
Yeah, so the patient that's having new symptoms, we would like to try and be able to screen those patients if we could via tele, as we're trying to convert pretty much everything to televisits here, at least in the near short term. By calling that clinic, we'll try and set up a telehealth visit to evaluate the patient and try to sort out mainly whether that patient has a relapse or sometimes what we call a pseudo-relapse. One of our concerns is that as patients get sick, a lot of times we see this with urinary tract infections in the past or colds, the flu. Also when patients have heat exhaustion and it's hot outside after exercise. Additionally, when patients are tired, so if they're under stress and not sleeping well, those kinds of things, some of the old symptoms can come back. And so I think trying to sort out for us a lot of times in visits what the difference is between a relapse and a pseudo-relapse becomes important. A relapse for us is new symptoms associated with inflammation in the brain and the spinal cord, and for that, we would want to try and treat with steroids. If it's a pseudo-relapse, and particularly related to COVID, we don't necessarily want to suppress the immune system too much more with steroids. And the idea would be to try and treat the underlying issues. So, for example, if it's fevers associated with COVID, we want to try and bring the fevers down. If it's dehydration, just not getting enough fluids in, we want to make sure that we push liquids and have the patient drink lots of fluids and things like that. So a lot of those kinds of things we can at least try to do via telehealth. We, again, are open for business in clinic, so if patients want to come into clinic, we can see them in clinic. If it's something that we need to evaluate more in person, we can see you in clinic and try and push for that as well.
Another question that's come in pretty often is talking about how much the Rocky Mountain MS Center is still open.
Yeah, so...
do you want me to go ahead?
Yeah, if you wanted to answer that, Carrie? Or
yeah,
Kelsey?
I just wanted to let people know the Rocky Mountain MS Center on the nonprofit side, we have shifted all of our education programming to online virtual options. That includes our education summit that's happening on April 18th. You can still register at mscenter.org to get the link for that, but everything will be online. Our King Adult Day Enrichment Program has temporarily closed, but we are offering online resources to clients. Our admin staff is working from home, and we are also working on developing a webinar with our MS counselor and educator, Alyssa Berlinger, to discuss strategies and tools to help individuals cope with stress and anxiety. So you guys are on our email list. You'll hear about that as it becomes available. One of the kind of more specific questions that we've seen come in is wondering, should people with MS who are healthcare providers be working, in the hospital system right now?
Yeah, so this becomes always kind of a tricky question to answer. I think a lot of it depends on what the provider is doing and their overall health status. We've gotten questions from respiratory therapists, for example, and just they're going to likely be much more exposed to higher doses of the virus. So for some of those patients, maybe we need to be a little bit more cautious. Just being in a healthcare environment doesn't necessarily increase the risk of infection by COVID, since we're washing our hands all the time, we're screening patients before they come into clinic, and those kinds of things. The other part that I think becomes partly something to think about is what treatment that patient is on, and how are they done with that treatment. So a lot of patients on our treatments, for example, will have fairly normal labs to see how they're doing, but some patients may have low lymphocyte counts, may have low other abnormalities in their labs that may cause concern from an immune system perspective. And so some of those patients, I think we can try and avoid having go into work in order to kind of protect some of their safety until maybe some of the labs become more normal, and things like that.
Before we move into opening up the Q&A, where can patients find the most up-to-date information and general recommendations?
Yeah, so as everybody can imagine, we're getting a lot of guidance from many different organizations. I think sometimes it's a little bit hard to bring all the guidance together and evaluate sort of what the risks are in putting in guidelines. So, for example, there's good guidance coming out from the CDC and the local branch, in the state of Colorado, being the Colorado Department of Health and Environmental Services, have slightly different guidelines around the age cutoff for patients at risk. I think it should become clear that just because you're 1 day short of 60 doesn't put you at much lower risk than the next day when you turn 60. The CDC recommends 60. The Colorado Department suggests 65. Again, these are curves that increase as patients get older, and so understanding that there's going to be some differences. For that reason, I like to look at the Colorado Department of Public Health, because they tend to be aware of what changes are happening in Colorado, so it's a little bit more local, and they can speak to more as to where we are at in the state, and you'll find more guidance around which counties in the state are more affected than others and things like that. So for those listening in other states, listening to their state's public health organizations, I think becomes important. Also looking at the CDC, they have a lot of great resources. And then again, the WHO, the World Health Organization, has great websites for people to kind of follow along. There are websites through both University of Colorado health system that can be looked at sort of from our hospital side as well. And then we are, putting up some information as well through the Rocky Mountain MS Center website as well. So I think that gives you lots of information, and again, paying attention to it regularly, just as things have been changing a lot. It gives us a good sense for where things are at, as far as, are the rates of cases jumping a lot, are they mainly stabilizing, and things like that.
Excellent. We are going to go ahead and take a couple of questions now. I am going to try to group similar questions together because we have gotten quite a few. If you haven't entered your question already, you can just put it into the chat screen. Dr. Alvarez, at what point do you think people should start considering going to the ER? Like, what sort of symptoms do you think warrant calling a doctor or going to the ER? And who is the first person that someone should contact if they've got MS? Is it their neurologist? Is it their PCP, or do they go right to the ER?
That sounds like a great answer. So I think it depends, or great question, I guess, and then we'll work on the answer, I guess. Part of this depends on the symptoms and where things are at. So if you are mostly concerned about, I got a fever, a runny nose, and a cough, but my biggest problem is my legs are getting weak and I can't move, I think reaching out to the neurology clinic is a great place to start. Going to the ER at this time particularly, I would really try to reserve it for things that are a little bit more on the life-threatening area, not so much that they're don't do a great job, but they are really dealing with high volumes of patients, and so you also, it's a little bit of a higher risk environment, so a lot of patients are coming in with those kinds of symptoms, and so trying to see what we can do through clinic at this point, I think, is a great starting point. If your symptoms are mostly respiratory, you have a cough and a cold and a fever, part of it is kind of the way you would imagine most colds. You don't necessarily go to the emergency room for most colds, and so it's going to be hunkering down and then trying to do the supportive care type things that we look at. So again, taking Tylenol, there's been some concern raised around taking ibuprofen with COVID. There's not a lot of data as to where those concerns have arisen, but I think maybe starting with Tylenol would be good to try and lower those fevers. Staying well hydrated, drinking lots of fluids, getting your rest, and things like that. If your breathing becomes short, you're starting to get that difficulty breathing, things like that, those are the patients then that we do want to start getting evaluated in the emergency room, and starting at those places, maybe reaching out to primary care providers to see whether or not maybe there's sites to get evaluated maybe outside of the emergency room, and those kinds of things, since there's setups being set up at this point for triaging of patients that don't involve necessarily coming into the hospital.
Do you think that having MS means, I'm not sure how to word this, that someone should be more inclined to get tested for COVID?
It brings up a good question around who should be tested and where can I get tested. It's a difficult question right now because, much to the chagrin of most of us, the amount of testing is really, really limited. The guidelines around testing has really changed over time, and we're limiting out, at least through, for example, UC Health, the testing has become so limited that they're really doing it only in patients that are hospitalized. The idea is to try and figure out those patients in the hospital that have it or don't have it so that we can conserve some of the protective equipment. The PPE, what you're hearing, is the personal protective equipment, the masks, gowns, face shields, gloves, things like that. If we can rule those patients out earlier, we can go through less of that kind of equipment and maintain it for patients, or the treatment of patients who have COVID. I'm really hopeful, and we keep hearing efforts to try and increase the amount of testing, but the state of Colorado, for example, has only done 3,000 tests, slightly under that as of yesterday. So this remains a huge area of need. And I wish it was differently, because trying to understand, what the spread is and things like that becomes important. What will happen is that other kinds of testing is available. So most patients, when they're presenting, they're getting ruled out for other things. So they're getting tested for the flu. They are testing for other types of coronaviruses. just basically the other types of common colds, so that at least we can get a sense and reassurance of like, hey, this doesn't appear to be COVID, it appears to be something else. So that's been the first line of testing for a lot of the other patients. That can sometimes still happen through primary care offices, although again, most primary care offices are trying to screen out patients that are sick and maybe are mild enough that they don't necessarily need to be coming in contact with the healthcare system. So from an MS perspective, it still applies that way. Even, for patients that have a little bit more of a lower immune system, unless they're hospitalized, it'd be hard to get testing for them. But we definitely want to be able to kind of be aware of what their immune system looks like and things like that. And then potentially as these conditions change, and hopefully it'll change soon, this will be an area that will have to be updated because I think it'll change by next week, I hope.
So I know earlier in the webinar we went over a little bit about DMTs and kind of whether or not people should be delaying them or anything, but we're still getting a lot of questions about specific DMTs. So I'm wondering if you can run down some of the most commonly prescribed DMTs at the MS Center and a quick run through of whether they should continue or delay. And then a specific question we've gotten a couple times is, should people consider switching over to an at-home treatment like Copaxone in this time?
Yeah, so let me run down through some of the individual treatments. So as far as we look at a lot of times what I call the platform drugs, the old injectable medications, the interferons and Copaxone, the challenge that we're facing with that has been that these medicines take some time to take effect. If you're already on them, we don't really think that they lower the immune system much. The effect on MS tends to be on the low side of things. They do work on a subgroup of patients. And so for those patients, I think it remains very reasonable to continue on those medications. On the fence I would mention as well for interferons that the reason they got tested as an option for treating MS was in the days that we thought MS was caused by a virus. And so this is a group of medicines that's sometimes used to treat virus-type infections. Now, again, how well or not, it's a product that the body makes to try and fight infections. So none of us really, very few of us, I should say, have interferon deficiencies where that should be much of a concern of, hey, maybe an interferon might help me fight it better a little bit. But some of those concepts are out there a little bit. The other, as we start talking about then some of the medications that are pills, Obagio, at least on a glass plate and in the lab, not in animal testing, has shown some benefits against some viruses, particularly viruses that I got looked at were things like PML, or the virus that causes PML, the JC virus and its related virus called BK. These are very different viruses from corona, so whether that really holds true in this situation, I think remains very theoretical, and I would not think about it as sort of an antiviral medication. However, again, the immunosuppression with that is very low, so it doesn't decrease white blood cells or some of the other groups of blood cells that we look at, such as lymphocytes or neutrophils, much. And so they're probably safe to continue as well. With the siponimides, Gilenya, with the S1P drugs, so like Gilenya and siponimod, potentially soon we might have ozanimod on the market. Those medications should be okay. They do lower white counts some, and so there's been speculation that they may be a little bit more concerning in patients who have infections with COVID. Again, we've seen some reports of some of those patients doing pretty okay with COVID, and our plan would be to continue that. As I mentioned earlier, Gilenya has actually entered a trial to see about being used as a treatment for COVID-19 itself. So again, just because it enters a trial doesn't mean it's going to work for that, but it at least suggests that the thought is that it should be at least okay to continue. Again, that doesn't necessarily hold for patients whose lymphocyte counts have dropped and are on the really low side. We might want to switch to every other day dosing, and some centers are doing that. We're not doing much of that because, again, we don't have suggestion that the immune system is lowered too much and that those kinds of patients are really susceptible to infections. The other oral medication would be the fumarate, Tecfidera, and Vumerity. I would be a little bit more concerned for patients whose lymphocyte counts are below 500. The lymphocytes, again, being a type of white blood cell count. We tend to monitor those routinely, and so those are the patients we would want to maintain an eye on their white counts. If you're at 500 or higher, the indication, again, is we're not seeing a lot of infections with that. We don't see a lot of common colds that are above and beyond what we tend to see in patients who are not on those drugs. And so because of that, we've recommended to continue drug, again, to minimize exposure to the healthcare system, trying to reduce how often we're doing blood work, pushing some of the blood work out, as long as the labs have been traditionally pretty okay. When we start talking about the infusible medications, Tysabri should actually be a medication that I'm not too worried about. The way Tysabri works is it prevents the immune system from getting into the brain and the spinal cord, meaning that the bloodstream has a normal immune system, which would allow you to fight an infection such as COVID-19. The CD20s are, I think, the one group of drugs that that's out there that's a little bit less understood. We have used rituximab, which is a similar drug in that they both take out B cells. From a theoretical perspective, that's concerning because that part of the immune system helps fight a lot of upper respiratory infections. Again, we do not traditionally see a lot of upper respiratory infections on patients on these drugs. And so if it lets you fight the common cold, which we've been dealing with every winter since these drugs were approved, we would have seen sort of an increased concern with COVID, in my opinion, if that was the case. So I think these are drugs that are probably pretty safe to continue. We're pushing them out again to reduce the contact with the healthcare system. We have data early from rituximab that a single dose works really pretty well from a relapsing perspective to push out relapses for at least a good solid year. If that's the case, then we feel really comfortable pushing out patients out 2 or 3 months if we have to. Certain patients, that's not going to necessarily apply to. So if you're somebody who has a lot of the wearing off phenomena, or as some patients have started calling it the crap gap, where just before your next infusion, you're getting a lot of symptoms and can really affect your quality of life. You know, we understand that, and in that situation, we want to allow to continue doing infusions. This is how to monitor these patients and things like this. I can tell you that we have a gamut of opinions within the group. We have some providers that want to continue infusing everybody. We have certain providers that are looking at trying to switch to other therapies, which I'll get to here in a little bit. We have some providers that would like to monitor the B cell counts and maybe infuse and once the B cells start to come back. Overall, most of the guidelines are to either continue treatment with them or consider pushing them out a few months if you have been doing well and things like this. Again, a patient who on their last MRI had an active lesion or something like this, those patients we still want to continue treatment for MS because we're more worried about the MS than we're worried about the COVID causing a bad infection in those patients. So the question about changing down therapies, if we look at trying to switch to some of the other therapies, the challenge that we have is how long will that other therapy take to take effect? And really if it's any safer than staying on the current medication. Again, we don't know that these medicines really increase the risk of infection. And again, I point out to the fact that some of these medications are being tried in trials. One of them, again, the IL-6 medicine that we don't use in MS, but we do use in neuromyelitis optica, is actually approved in China for the treatment of COVID. How effective against COVID it is and those kinds of things also become an issue. So I don't want to say that we have treatments for the COVID, but I think the issue is that we don't know that the medicines put you at higher risk. They may be putting you at lower risk. And so if there's concern about some of these things, seeing your provider, scheduling a telehealth visit, and discussing it becomes important. Hopefully that answered that. That was a long answer.
No, I think that was great. What can people do to boost their immune system safely? What kind of over-the-counter, vitamins or supplements or anything? And kind of, we'll start there.
Yeah. So remember that the immune system is in a tight balance, and it's always difficult to kind of push boosting up the immune system, because if you boost the immune system, we can see an increase in MS relapses with certain things, right? So a lot of the over-the-counter things don't probably do this in any way that really matters too much. Things like vitamin C, zinc, things like that probably don't do much. There's been some groups of medicines used for cancer with the idea of trying to boost up the immune system really a fair amount, where we have seen reactivation of MS or sort of resulting in MS-type relapses in patients that were maybe susceptible to MS. So a little bit of word of caution on boosting up the immune system with drugs or things like that, just with that balance of MS versus being able to fight off these infections. Importantly, though, the things that are going to let you get ready for this as much as possible are not worrying or stressing about the conditions that we currently live in. That is easier said than done, and I understand that. I understand next week there might be a webinar coming up on sort of mental health, and I'll let Kelsey here in a second maybe kind of touch on that. The important point is to stay mentally and physically active, and that's a little bit harder sometimes when we feel like we got to stay indoors, but still go to the parks, go for walks, go for hikes, exercise, be active, eat well, don't eat canned soup all the time and beans. I mean, you can still go to the grocery stores. Fruits and vegetables are not running out at the grocery store, so eat well, get your sleep, exercise. That will get you the best prepared shape that you can be to fight off COVID, should you be one of the people that gets it. And remember, again, probably most of us will get it. It's just going to be a matter of time before that happens, and we're trying to spread that out as much as we can. Kelsey, did you want to comment on the webinar next week?
I don't have a whole lot of details about it. Like I said, it will be led by a licensed clinical social worker, and we will announce it through our Facebook group or our Facebook page and email. So just keep an eye out if you're interested in that resource. What about
Perfect. Some more information coming.
Yeah. If people haven't gotten the flu shot yet, should they get it? And if they got it really early in the year, last year, should they get it again?
So I wouldn't get it again if you got it earlier this year. If you've not gotten it, I think it's always a good time to get the flu shot. We are seeing, and some of the numbers I've seen, is that 2% of patients who develop the flu can get COVID. So trying to kind of manage both of those symptoms as much as possible becomes important because if you can control one of them, you're much likely to do better than if you end up coming down with the flu and COVID on top of it. So as much as you can, I think that's very reasonable. I think it helps highlight, though, more importantly, because we're coming at the tail end now at the flu season, about the importance of getting vaccinated for stuff that we can vaccinate for. And it teaches them an important lesson, right? So a lot of times the idea with the flu is you may not get exposed to the flu virus exactly that the flu vaccine works against, but you might get at least some protection so you don't get the worst flu if you did not get vaccinated. You might get a milder flu, or if you do come down with something for a day or two after your shot, you know, a little bit of muscle aches or something like this after a shot is completely fine. And we want to emphasize again that pretty much every MS patient should be getting the flu shot. I think that's the important takeaway.
Kind of piggybacking on an earlier question, we had a question, a concern about a lack of physical activity currently on top of potentially delaying a DMT. And I just wanted to remind people that on our website we have a lot of resources for being physically active with MS. Dr. Jeffrey Hebert, if you search his name on our website, you will get various webinars and articles from him. And one of the most recent Informed magazines was focused solely on exercise. So there's some good ideas there for how you can get in more physical activity or what the right amount of physical activity for you might look like. So I encourage you to check out our website. Do you know, is there any information on if it's helpful to use an asthma inhaler if you end up with breathing issues due to COVID?
Yeah, so especially if you end up with COVID and you're somebody who's prone to asthma and hence why you might have an inhaler, trying to treat the symptoms of the wheezing, it's one of the symptoms you want to be able to manage with these infections. I just got notice that there appears to be a national shortage of inhalers, so it may not necessarily be the best time to try and refill for an inhaler if you don't need to. But again, treating any symptom that you normally would get would be important.
We've had several different variations of the question. If I get COVID and it causes my MS symptoms to kind of flare up due to infection in the body, or, you know, if someone's been stable for a while, but if they get an infection like COVID and it kind of exacerbates MS, do we have an idea, does MS go back to its, you know, is that more of the pseudo exacerbation that you were talking about? Does it settle back down? What kind of thoughts can we give about that?
Sure. Yeah, so if symptoms occur in the setting of COVID, it's most likely then related, and I would say COVID, the common cold, the flu, or any other type of infection, those symptoms are more likely to be one of these pseudo events. And again, they're not fake symptoms, they're real symptoms, but they're not being driven by that inflammation in the brain and the spinal cord. I would also like to emphasize that just because of these infections, you're not at higher risk of developing relapses, so that it will not drive the inflammation in the brain and the spinal cord as we understand it. What we sometimes have seen, and something to think about, is something called Guillain-Barré syndrome that can happen after some of these viral infections, and that's something that sometimes we need to watch out for as well. But from an MS perspective, it ends up resulting in just control of the symptoms and going back to where you were starting at from before that episode. Sometimes we do see a little bit of a step back, and that has to do with level of activity during those episodes. And so if you're laid up for, you know, several weeks because of these infections, you know, sometimes it can be a little bit hard to kind of get back into the exercise and getting your stamina back up. And so trying to kind of exercise now ahead of time becomes really important.
Have you heard any specific concerns for women who are pregnant or having just delivered a baby and COVID?
Yeah, so there's we do consider pregnancy to be an at-risk group. I would say that's still pretty theoretical. We've not seen any cases, any concern of the virus crossing the placenta and infecting baby or things like that. But we would want to be particularly aware for moms that might be pregnant to be cautious, to try and limit exposures, wash your hands, and do a lot of the same guidelines as we talked about before.
So we've gotten a couple of different questions as well about if you get COVID, can you be reinfected? And then also, if you're recovering from it, should you throw out things like toothbrushes, etc.?
It's an interesting question. Normally, I would have said that the chances of getting reinfected with it is pretty much non-existent because after you clear these infections, you tend to develop antibodies that protect you from that infection next time. So a lot of times, just because you keep getting common colds, there are different strains, different mutations occur that allow that virus to kind of reinfect you. Same thing with the flu. Recently, there was a couple of articles as to whether that happens or not with the COVID and kind of being up in the air a little bit. And so I would not necessarily throw out things that you're going to continue to use because the chances are that you'd be protected against those. But anything to other family members that would kind of give a high dose of virus to other family members or things like this. In other words, use your own towels, use your own toothbrush. Hopefully that's happening already, but just in case, those kinds of things, as much as you can, keep your own. I probably, once you're getting better, would consider maybe switching out the toothbrush and things like this. But we don't really have great idea as to what that's going to look like. Again, it's one of these areas that we have a lot more questions that we have answers for.
As far as social distancing goes, we've got a couple of questions around if you can't drive, what's the best way to get to and from infusions? Are things like ride shares and Accessoride suggested? Can we have friends do things like curbside pickup? Like how much social distancing is recommended?
Yeah, I mean, let's see. So general guidelines for that would be to, it depends a little bit, again, on risk. So if you're really high risk, your labs are somewhat concerning, you're in that really kind of older age group, higher disability levels, we're going to recommend to be much more strict on some of these things than if you weren't. Again, the benefits in patients that are very disabled and older for MS really need to be questioned. And so getting to infusion centers for some of these patients, that would be the group that I would say really probably doesn't get much benefit from infusions and probably needs to look at trying to really push out those infusions initially. But on other side of things, getting drive-through for food and things like this, most of those things should be fine. We still need to get groceries. We still need to do things. The things I would do would be wipe down the handlebars of the grocery cart, washing your hands when you get home, really making sure that you wash your produce when you get home. Emphasizing a lot of the things that we know we should do that sometimes maybe we don't, but those are the things that I would particularly worry about at this time.
I'm assuming this question is for the infusion center at the hospital. Do you know, is the patient responsible for rescheduling any infusion if they choose to delay, or would the infusion center reach out directly?
Man, I definitely come down on the maybe for those. So we have reached out to the infusion center to help us delay some of these infusions. It is always good if you're on top of it to try and reschedule infusions. We again, as far as the 2-month thing, this is more of a guideline, just expecting that we were going to be at least in this for 2 months. If we're in this for 3 months, I think, these become conversations that you need to see as to how well are you doing, and things like that. It becomes a discussion with the provider, with your provider specifically, to kind of see, how far do we think we can push you out. We can make suggestions and things like this, but there's clearly some patients that are going to maybe make it to 7 months. Maybe some patients might make it to 8 months. For most patients, again, for progressive disease, patients that have done really pretty well with the infusions, getting out to 7 to 9 months should be, fairly safe to do. Some of that becomes if you were recently, one of the questions that came up earlier was for newly diagnosed patients. We want to get treatment on newly diagnosed patients for the most part fairly soon. We're still worried about MS. It becomes a discussion with the provider as to whether the drug that you picked was still the right drug that you want to continue on, or whether maybe some of that should be pushed out or switched to a different drug. Generally speaking, stay on top of it. It's the same thing we hopefully tell you in clinic when we're getting you started on drug. They should communicate with you, but if they don't, stay on top of it. And if you've not heard something, to reach out.
I have just one more question, and then I'm going to go ahead and wrap it up. But I wanted to clarify the B-cell drugs that we've been referring to are Ocrevus and Rituxan. And then Dr. Alvarez, if you could just say a bit about Tysabri, since it is not a B-cell drug, but it is an infusion. I wanted to make sure we separate that out.
Yeah, so B-cell drugs. What was that last bit, sorry?
Just whether or not it should be considered to be delayed or not.
Okay, yeah. No, great question. So B-cell therapies, yes, that includes rituximab or Rituxan, and also ocrelizumab or Ocrevus. We do have some patients who are in clinical trials with other B-cell type drugs, and so that might include ofatumumab, OFA as we like to call it, or ublituximab, are all drugs in that class. So when we're talking about delaying, those would be the ones that we're thinking about, that in some patients it may be okay to delay, in other patients maybe not so much. For Tysabri, and I'm going to include Gilenya in that discussion as well, those two medicines we definitely do not want to delay taking. I would emphasize that we also don't want to have people stop their drugs without reaching out to their doctors. Particularly with those two medicines, the concern is that when people stop those drugs, we can see rebound of disease activity, meaning the disease can come back, and it come back with a vengeance, and it's something that we do sometimes see. And so by stopping this medicine, we just don't want the MS to get angry at us, and we can see that happen. So those infusions with Tysabri, patients taking Gilenya, we want to continue those two therapies for sure, unless we've made plans to switch out to something else. And a lot of times we will continue those medications until you can switch out to something else.
Excellent. I think that is a really great place to wrap it up. We're also out of time. We have received a lot of very specific questions about specific drugs, specific timelines. So I'm just going to reiterate, please reach out to your MS neurologist to discuss those specific questions. You can do that through My Health Connection or the clinic phone number, 720-848-2080. But those should be discussions between you and your doctor. But thank you all for joining us this afternoon. Thank you, Dr. Alvarez, for giving us your time and this very important information. This session has been recorded, so if you missed any of it, we will be emailing it out to you this afternoon.
Perfect. Well, thank you very much. I hope that was helpful for everybody. We will try and review some of those other questions as well and see what we're not thinking about sometimes.
Thank you.